getting help and finding recovery, and her motivation was to be there for her child. And she was terrified. She had been through this many times before, and she was terrified that the first time she felt withdrawal, that it would be over, and it would be over for her, and it would be over for her baby, and it would be over for their relationship together. So the fact that we were able to see her in a clinic appointment the same day that she left the hospital was really the only thing that made her feel like it was going to be possible. And it's really a shame that it took a worldwide pandemic and the policy changes related to that pandemic to have that be a reality. The second, part of this, without which this would not have been a successful case or a possible case, is the work of Kelly, our CRS, who I don't know, how many hours or days she spent at this patient's bedside while she was inpatient, advocating with the inpatient team and the OB team and the OB case management team while she was transitioning to be discharged, was really there to reassure her, look, we have this plan, it's going to work, just trust us. And when she got home and realized that the technology was clunky and difficult for anyone to use, nonetheless, someone who had just given birth, literally stayed in her house with her mask on, 6 feet apart, but stayed in her house until I came on and met her. And without that level of support and championship, this patient, I don't know that we would have been able to engage her and, in fact, have her remain in treatment and recovery to this day, where she continues to be a mom to her new baby, as well as an advocate for herself.
10 months later, Kelly's still involved with this patient heavily, and the patient is still engaged in a treatment program. Tara's going to tell us about what certified recovery specialists are.
Thank you. I was on mute and I was speaking. So I'm defining certified recovery specialists from the Pennsylvania Certification Board. The CRS is a credential issued by the state for individuals with lived experience with substance use disorder and recovery. Recovery services are an important component in the recovery-oriented systems of care. By offering insight into the recovery process based on their own experience, recovery specialists are able to provide a unique perspective to those with similar life experiences. As a CRS, an individual accepts and agrees that their experience as a person in recovery from substance use disorder will be known to their colleagues, persons served, and others with whom they may share that they have achieved that credential. Pennsylvania requires 18 months of sustained recovery. It is now 78 hours of classroom training, passing of a state proctored exam, continuing education for recertification every 2 years. CRSs are held to the same ethical code of conduct as clinicians. Next slide.
So the way we utilize certified recovery specialists in an acute care setting is unique. So from a personal perspective, this role is so close to my heart. As a peer, which we heard a minute ago, and I'm an overdose survivor, I wanted to engage patients in this milieu. My goal was to be the support that I and many, many people that experience an overdose or show up to the emergency room in withdrawal or are looking for support. Before this initiative, this warm handoff initiative, we weren't really afforded that support bedside. So for me, meeting patients bedside in their most vulnerable hours has been both rewarding and eye-opening. At Penn, we are widely included in the care teams. We work so closely with the patients and the physicians, whether it be the emergency room physicians or the hospitalists throughout the health system. So we're able to support the patients and provide advocacy and treatment education. Logistically, in the emergency room, when a patient presents, regardless of what their chief complaint is, either an alert system, where a physician will trigger a bedside consult. The one and only goal that we have throughout the health system at Penn Medicine is that our patients leave the hospital feeling cared for, no matter what that looks like. We may not know exactly what the needs are, but we, as a peer, we can meet the patients, talk through what their needs are, and provide the best care. Next slide.
Hi there. So peers in the community, it looks a little bit different than Nicole's description of peers in the ED. Community-based professional peers provide mobile, one-on-one, non-clinical recovery support. So we meet you where you're at, both figuratively and literally. Figuratively, meaning that CRSs meet with participants wherever they are on their journey, from active use to sustained recovery. And literally, which is wherever they are in the community, be it at a clinical level of care, a correctional facility, a recovery house, a coffee shop. As mentors and advocates with lived experience, much of our work is addressing barriers to recovery and reducing stigma. The approach is individualized, it's strength-based, person-centered. The CRS empowers the participant to define their own recovery. The CRS will support multiple pathways to recovery, regardless of how that differs from their own. Pathways vary from harm reduction strategies to abstinence-based programs and in between. The CRSs serve as a conduit to clinical and healthcare systems, social services, and community resources. Community professional peers will also work in coordination with other providers to offer participants a holistic approach at recovery. At the request of the participant, CRSs will also advocate with the criminal justice system. This is a very unique relationship, and it's cultivated over time, and it's maintained for years for some of our people. So I'm going to pass that on to Utsa.
Sorry. Thank you. Thank you. When this pandemic first hit, those of us who work in the space of substance use and opioid use, and just in this population, we were all terrified. We knew from day one of the stay-at-home order and the social distancing recommendations that our patients in our community were going to disproportionately suffer and disproportionately be affected by what was already an uncontrolled and overwhelmingly increasing opioid crisis. And while data in this space is late to be reported for many reasons, this recent report that was just released in December of 2020 shows that that was absolutely the case. The 12-month period from June 2019 to June 2020 has shown the highest number of overdose deaths in the United States in a 12-month period in history. And this has been true for all substances, but especially for opioids and synthetic opioids like fentanyl, which has contaminated most of the opioid drug supply. Next slide, please. And this is true all over the country. I know all of us are working in Philadelphia, and a lot of you who have joined us today might be local, but wherever you are or wherever you have colleagues or friends or families, this has really been the case. There are lots of states that have incomplete data reporting, and so some of the lighter shaded states represent those. But on average, there's been an 18 to 20% increase state by state in overdose drug deaths this year. Next slide, please. And go ahead, Nicole. We were just going to talk about why this was the case.
We may not know exactly what's causing it, but we can hypothesize. So, of course, there's social isolation, which we're all experiencing, but especially our populations. There's the stressors, the job loss, and which causes either active or potential homelessness. Those are just a few examples. We do know, according to the DEA, the supply chain was disrupted during COVID, and programs that were opened, that were in person, clinical levels of care, or just NA meetings or AA meetings, wherever our people found support, were closed and struggled to scale, to do telemedicine and creating an environment while the CDC guidelines in mind. And also our ED population, and UTA can speak more to this, that face so many social disparities to begin with. They felt very scared coming to the emergency department in case of they didn't want to expose themselves to COVID.
Yeah, absolutely. We saw in the first several months of the pandemic, we saw decreases in volumes across the board, whether that was related to substance use and overdose or related to heart disease or asthma, whatever the case was. Patients were afraid, they were terrified to come to the emergency department. So if you add that baseline level of fear of contracting COVID and fear of going to public spaces on top of the challenges our patient population already faced with stigma and with being with their needs and concerns not being empathetically addressed, we definitely saw a decline in this patient population presenting to the ED.
The depopulation of the jails we were really concerned with, that contributing to the overdose increases. Next slide. Again, the barriers in the emergency department, the biggest one, it wasn't just our population not showing up. We know that nobody was showing up to get treatment in the emergency department, but especially our patients that suffer from opiate use disorder. So we had a hard time finding our people that we knew needed help.
And at the same time, there were a lot of rapid changes made at the health system level across the country and including at Penn that limited who could be on site. We knew very little about the virus and how it spread, and so the decision was made that to limit the number of people and staff who were allowed to be in the emergency department spaces. So initially that included Nicole and her CRS colleagues who were otherwise in the ER every single day, suddenly being told to stay back until we had a better idea of how this pandemic was going to play out.
Next slide. So we made a lot of calls together, Utsa and I, and many of our ED doctor colleagues and our community colleagues were trying to figure out how are we going to deal with these barriers, because we needed to do something. We did know that technology was a major contributor to disconnection from programs and disconnection from buprenorphine treatment. So we did reach out to the William Penn Foundation, and they were kind enough to provide us. We could get some phones and some transportation funding and miscellaneous needs that we knew that our patients were going to experience. And Utsa can tell us more about the warm line.
At the same time, as I just mentioned, because our CRS colleagues were initially working remotely, we realized that we needed a way to engage them in the care of our patients who were in the emergency department or who were coming in to contact, and many who may have not been in the clinical care spaces. And so we rapidly created what we call a warm line that really wouldn't have been possible without a huge team of student volunteers under the leadership of Dr. Heather Kusaris, who's from the School of Social Policy, to rapidly set up a phone. We used Google Phone, a Google phone number that was triaged to our cadre of volunteers who answered the phone and then connected callers who were seeking treatment services to one of our CRS colleagues to their phones. And this line was widely advertised. We advertised it amongst community organizations who do extraordinary work in this space, but we knew we're being overwhelmed with the pandemic and pandemic response, as everyone was. We advertised it to our colleagues in the Philadelphia Department of Prisons because we knew that they were working on efforts to depopulate the jail there as well, and many of those individuals were going to need extra support services upon reentry. We advertised it on Twitter, as we did for our webinar today because we know the power of social media in reaching people who are otherwise not in our direct circles. And through this line, which continues to exist today, we've been able to connect multiple patients into treatment, and if not treatment, into services under our CRS colleagues. The second thing that we did, which was exciting development in terms of keeping our patients connected to the CRS program, was to use the iPads via telemedicine consults. This was a program that was already being set up in our emergency departments because, as I mentioned, it wasn't just CRSs who weren't in the emergency department. It was all of our consultants. Ophthalmologists, dermatologists, neurologists, a lot of providers and provider teams were doing care remotely because everyone was terrified of this virus. And so because of the need, there was a program set up by one of my colleagues, Dr. Agrawal, who made it a seamless process to consult other providers through iPads for our ED patients. And because everyone within our department recognizes our CRS colleagues as integral to our team and a consultant that we depend on and who we get recommendations from, they were included in the same process. And Nicole and I saw patients together via iPads, which was really fun.
We did. That was great when that got set up. I know we had to use, Utsa and I had a mutual patient and we had to become innovative and use FaceTime before the iPads came. So we were really trying to find ways to ensure that our patients were connected. Another response to the COVID, we did a lot of community outreach in person in the community, respecting social distancing and wearing PPE. But it was an effort to find our people that weren't coming to the emergency department. We knew that they were out there. We knew that they were struggling. Many didn't have phones to stay connected. So we really needed to go boots on the ground and find our patients. We hit the streets just to share some love, some snacks, some resources. One takeaway, and it was a day that Utsa and I both went out, was that we did notice in very early COVID, there was an intense need for harm reduction resources such as Narcan, condoms, fentanyl test strips, and wound care. Fortunately, due to us being in the spaces of harm reduction, we did have those resources and we were able to provide them. But it did give us even more anxiety because we knew what was happening out there. So we just continued to find our people and provide the resources that they needed on the streets. Next slide. And Tara's going to tell us about the barriers that she faced being a community CRS.
So in the community, much like the emergency department, the technology issues, that was the first barrier, and that was a barrier for the staff as it was for those that we serve. Another barrier was Medicaid reimbursement. So for prior to COVID, telephonic recovery support was limited to only 20% of engagement time for fee-for-service providers. Inpatient bed availability was very limited due to social distancing. There were COVID outbreaks in the facilities, which perpetuated the patient isolation, changing the traditional the group rehab experience. Aftercare planning, little to no outpatient availability due to slow telehealth implementation. Discharging patients were often provided just a 12-step Zoom meeting list, and that was it. Absence of structure from the adult probation and treatment court system, leading to overdoses of many of the mutual participants. Early release from incarceration, no connection to support and resources, also leading to increased overdoses. Loss of employment, folks lost their jobs, obviously, and that caused a challenge to pay their rent. Reports of increased or new mental health symptoms. RCOs, recovery community organizations, they had to close their doors. So the absence of recovery support and socialization was also a barrier. Mutual aid and self-help programs were suspended initially. Next slide. So how we responded to that, developed a telehealth model for providing one-on-one recovery support services. The CRSs educated and assisted the clientele with navigating virtual platforms. OMTOS and Medicaid waived the reimbursement limits, allowing fee-for-service providers to bill 100% for telehealth. We conducted research to identify various admission protocols employed by specific inpatient facilities, and we monitored their statuses because that was ever changing. CRSs became more of an integral part of the aftercare due to limited clinical programs available. We developed a streamlined process with specific inpatient facilities for referrals from those providers to our program. The CRS orientation sessions were then conducted telephonically prior to the patient's discharge from inpatient. In response to the absent structure ordinarily provided by the local criminal justice system, combined with the increased overdoses, we implemented weekly virtual recovery groups for almost 300 treatment court participants, and that was drug treatment court, behavioral health court, and veterans court in Montgomery County. That is actually still going on right now, and the system decided to make that a mandated program. We provided resource packets with current programming to local correctional facilities for early release inmates. The CRS advocated on behalf of their clients to recovery house owners to ensure no one would be homeless for not paying their rent. We partnered with recovery houses to assist residents with applying for unemployment and pandemic relief. And the CRS advocated and coordinated mental health supports for the participants. We facilitated recovery, the recovery community organizations that had closed their doors. We were able to develop programming via virtual platforms to provide recovery support and social integration. Next slide.
And at the same time, there were lots of policy and clinical practice changes that were happening very rapidly that allowed for a lot of the adaptations that we've described so far. So the first one, you've heard us say telehealth and telemedicine throughout this webinar, and that was really that was the only option. And it wasn't just for substance use care, but really all of medical care transitioned very quickly to telehealth. The key policy change that affects our population was that for the first time through policy changes made in the pandemic crisis, we were allowed to initiate patients, meaning new patients, patients who had not had an existing provider, such as the patient that we presented in the beginning, to opioid use disorder treatment and initiate buprenorphine via telehealth alone, including audio-only telehealth, which means not having the need for video conference, which is really, really important when we're talking about equity in this space, because video teleconference, computers, broadband internet, a lot of our patients don't have that. So being able to initiate treatment via telephone conversation was a huge policy win in this space that a lot of us are continuing to advocate for beyond the pandemic. There were also changes made to what the insurance companies would cover and pay for, which is also very important when we're talking about chronic disease management and having repeat visits, making sure that the providers and the clinics are being reimbursed for the care they're providing via telehealth. In my practice and many others, we relaxed the need for urine drug screen collection. The risk of having someone come in to a lab or a clinic, in my mind, that was just not worth the potential exposure to COVID. And so in place of having a urine drug screen, a lot of us in our clinical practice had to adapt to just asking our patients, like, how is it going? Have you had to use, this is a stressful time. Has the stress led you to use again? What can I help you with the patient being at the center of my visit rather than a urine drug screen being at the center of the visit. A lot of us were also handing out or prescribing longer periods of medications, especially to our older and chronically patients that have chronic medical conditions, to limit their trips to the pharmacy. And so instead of the 1 week prescription, we are doing 2 week prescriptions, and et cetera. Our patients who get methadone maintenance treatment, we're also experiencing some policy changes with additional take homes and mobile units that were set up. And then we talked a little bit about our efforts within the jails to try to, engage patients. But that in Philadelphia and across the country was a big effort to depopulate the jails. A lot of people who are behind bars are there pre-trial, and so the risk of contracting COVID was high. It continues to be high in jails and prisons, and so really trying to figure out how we can get people safely home while they're waiting for their court case was a big priority. And our efforts to try to engage them, whether in the hospital or in the community, was a big change as well. Next slide, please. And then this change, which we're all super excited about, and maybe some of you have already read about this in the news, but it just happened last week, where there's been a change to the regulations needed for doctors to prescribe buprenorphine. Now, this isn't a total win. We still need this policy to be changed so our colleagues who are nurse practitioners and physician's assistants who take care of this population just as we do should also have this policy apply to them. But for now, the policy allows any doctor, any MD, whether you have received this additional 8-hour training or not, to prescribe buprenorphine, which, as you can imagine, really increases the number of providers who can help this patient population. And Nicole can tell you from her experience working in the hospital how many hours of her life she's going to get back by not having to hunt down a X-waivered provider in the hospital.
No, that's right. This is really exciting in my little world. We see patients throughout the entire system, whether they are on the medicine floors or a cardiac care unit. And, it may be a unit that doesn't often see patients with opiate use disorder that would benefit from medication. So when we do end up with a patient on in one of the departments that's not prepared to, write a bridge script, there's nobody that's X-waivered. So as the CRS, we have to call in favors. We call our colleagues, and I call UTA and beg for, I don't have to beg. UTA is more than welcoming a bridge script phone call. But it does take a lot of time. It prevents a little bit of engagement from the provider, because if the provider is not waivered, that conversation doesn't happen early on until maybe a patient's in withdrawal. So this policy change can, opens the door for more, not only more bridge prescriptions, but more engagement because of awareness. So I'm really excited about this, and I hope that other departments are able and equipped to start patients on evidence-based treatment.
And thank you, Jean, in the chat for pointing out that while this policy change has been made in paper, operationally it hasn't been enacted yet, and we still have many steps to go to make the increased access a true reality. But we are very excited for this change that many of you on the call have been fighting for decades. So thank you for pointing that out.
Absolutely. We have to be so encouraging to get our, because we have many, many X-waivered providers, and UTA can speak to this more, that don't use the X-waiver. So where the policy changed, it doesn't mean everybody is going to start prescribing. I do think that that's an important part where peers come in, because I know when I started in the emergency department, we weren't writing that many bridge prescriptions. We had many champions that were doing this. But really, I learned, and I didn't know that this was going to happen when I got to Penn. I was able to support providers through, say, their first prescription. They would say, like, can you just stand with me while I write this prescription for the patient? Or can you make sure that it's okay? And I did, and then we celebrated. We had pins that say I'm waivered and I use it. We really high fives that we use throughout the health system, which is a virtual high five that everybody can see. A lot of positive reinforcement. And what the CRSs did in the early days was provide, because we would stay in contact with the patient that bridge prescription was written for, right? So we would email the physicians and let them know how successful the patients were after they left the emergency department.
Absolutely. Next slide, please.
All right, so we're wrapping up a little bit before the 45-minute mark. This will be a little shorter than an hour, but as you guys heard today, COVID has made some issues we were already facing worse, and it's created some new ones. Fortunately, there were a lot of people who were able to come together to find solutions, and peers were playing an integral part throughout the process. We're hoping to see the practice expansions that Utsa touched on and have been discussed today continue after the pandemic, and that the peer role will continue to expand in these spaces. So lastly, if you are interested in getting any more information about the work being done at the Center for Addiction Medicine and Policy, we have the website there, as well as upcoming event information. If you have any questions or want to get in touch with any of the speakers, you can reach out to me. I'm the one who sent the confirmation emails. And our next webinar in the series will be in mid-March. We'll announce the date and the rest of the series later this week, but we're going to be talking about changing culture in the health system around stigma and peers. So now we can get to questions.
Utsa, can you touch on how HIPAA was a factor using FaceTime?
Yeah, thanks for that question, Jean Marie. That was one of the loosened policy regulations initially, and that continues to remain in force as the pandemic is ongoing, that technology to communicate with patients no longer in the time of the pandemic crisis does not have to be or doesn't have to meet the full HIPAA requirements, which are pretty clunky, and the software that is, HIPAA compliant is a barrier because you have to download it, you have to have a login information. It's not intuitive to use, and it wasn't for our patients. And so early on, people have gotten very creative using either FaceTime or WhatsApp, other forms of software that isn't HIPAA compliant, which has been, permitted in light of the loosened regulations. But as a clinician working in this space, if I had 15 minutes and I had a new patient, I would spend 13 minutes trying to help them navigate how to download the software. And obviously that's not that's not what the visit is for.
Thank you. That's great. I'd love to hear how some of your programs, because we learn from each other, right? How some of your programs were really innovative during COVID. And if Kelly is here, I would love to hear from her. I see her picture, but I don't want to call her out if she's not sitting at the computer. But if she wanted to talk a little bit about the patient that she and Utsa shared.
She can't go off of mute. Sorry, none of the participants can do that. Sorry about that. But there is another question about audio versus video telehealth and how to maintain access for patients who don't have smartphones or internet access.
Yeah, that's a great question, and one that a lot of us are trying to advocate for. I mentioned that in light of the pandemic, they made some temporary changes where we could initiate and engage patients via audio telehealth alone. And that why that was important is because we know disparities exist within the telehealth space generally, not just in substance use treatment, but generally telehealth sometimes exacerbates disparities that fall along the lines of geographic access, with a lot of patients in rural areas not having the same level of broadband, racial and economic lines as well. And so the push that a lot of us on this call are involved with to try to make this change to allow audio telehealth for initiation of buprenorphine a permanent change, not just a pandemic-related policy temporary change, is one that is really important. And then, of course, as Dr. Lowenstein's pointing out, this doesn't fix the problem completely, because access to smartphones continues to be an issue, or telephones at all. And so this whole discussion is really trying to lower the barriers. There's so many barriers to getting people into treatment, and the pandemic has exposed a lot of them, and has exposed that a lot of them are unnecessary and unnecessarily placed. And so the more of them we can take down to make sure patients can access the treatment they want and need, that's our goal.
Robert, that's a great point. We had to do the same. There's a ton of administrative barriers, getting the phones and ensuring that they have the minutes, and making sure that we keep the service on. So I agree, the phones were about, but it was so hard, just like seeing our patients come into the emergency part, know that they want treatment, but they had no access. Everything was telemedicine and no access to phones. So that was heartbreaking. So thank you for your amazing work advocating to get your patients telephones.
And we should also point out the amazing work that our colleagues who work in the community have done over the last 10 months, especially folks at Prevention Point, who serve a population that often faces these challenges we're talking about, and allowing folks to drop in, use telehealth, whether iPad or phone services that are set up for them in a way that keeps the COVID social distancing restrictions in place. I think that has been huge, and as well as the work that Dr. Lowenstein and others do with the mobile units. Not everyone is going to be able to benefit from at-home telehealth services, and so that's important to keep in mind.
The resources, thank you, Maggie, for your question. The resources that we had to look to community organizations for funds to be able to get phones, but we do and still have some available through Penn. Tara, can you talk a little bit about how you made sure that the people that were engaged in treatment courts stayed connected if they didn't have the technology to do so when they made it a requirement to show up to the groups?
So we were able to apply for emergency technology funding from local nonprofits that were supporting our nonprofit in order to be able to provide the technology, like the government phones and what have you, to the participants in order to attend these groups that were later mandated. So we were very grateful for that those resources were available. There was a lot of emergency funding that we were able to access. So that was really a wonderful thing, because the people are still using them.
Robert, you are absolutely correct. The free phone, so it's really hard to get the video to work properly on the free phones. I do know SafeLink too, and the quality, I mean, it's better than nothing. I don't want it, but the quality is very sketchy. Oh, Kelly came in. Thank you, Kelly.
Yeah, thanks so much, Kelly. And hopefully in our next webinar, we'll be able to allow everyone to speak by the question answer portion.
Kelly, you did such great work with this patient and kept her engaged for so long. And really made a difference in her newborn's life and her life. And I'm honored to be able to share the story the work that you did.
If there aren't other questions, if I could just say, just to reiterate, thank you to Nicole and to Tara and to all of the other certified recovery specialists who may be on the call with us today. The pandemic has been horrible for everyone. It's been a total nightmare. But without your genuine commitment, expertise, and just care in this space, I just don't know at Penn and elsewhere how much worse things would have been. And Nicole and I have been on so many calls since the beginning of March, just trying to think about how we can reach patients that we were all very worried about. I working in the emergency department, a lot of our colleagues who work in outpatient clinics, and she had an answer for everything. She had an idea for every barrier, and I don't have the words to express the gratitude for our peer recovery specialists who have worked tirelessly this entire pandemic. So thank you guys for sharing today, and thank you for all the work that you do.
And from our end, Utsa, thank you for that. From our end, we wouldn't be able at Penn to do what we do without the support we have throughout the health system from physicians like you. We can't write prescriptions. So we really, the team approach, the multidisciplinary, inclusive team that we that we are afforded throughout our health system and hopefully other health systems, and we learn from each other, has really been the game changer for us as peers. There are people, we don't have to do all the things, right? Because we can't. We have this big health system, this big team that's willing to help the patients, that wants to help, that want to help the patients. So we're really fortunate for that on our side.
And I'd like to add that I sent a survey in the chat about if you could give us feedback about how we did today with our first session, and if there's information you'd like to learn about or hear about in our future sessions, that would be really appreciated.
Yes, thank you, Alex. We're learning. We're learning from you. We're learning trial by fire. So thank you for being patient with us, and we will take away all of the lessons learned from this first session. So thank you.
Thanks, everyone.
Yeah, thank you for coming. Bye.